Here. I'm so excited to have our speaker with us today, Dr. Julie Swann. Dr. Julie Swann is the department head and an A. Doug Allison Distinguished Professor of the Fitz Department of Industrial and Systems Engineering at North Carolina State University. She co-founded the Center for Health and Humanitarian Systems at the Georgia Institute of Technology, and she was previously on loan to the Centers for Disease Control and Prevention as a senior scientist advisor for the H1N1 pandemic response. She is also a member of the professional organization INFORMS and a fellow of the Institute of Industrial and System Engineers. We also have Ms. Blue. Ms. Blue is an academic advisor for the Edward P. Fitz Department of Industrial and Systems and Engineering, and we welcome them. And as far as a housekeeping, we will use a Q&A as opposed to the chat option from previous sessions. And remember, this is so important. As a community, let us respect what is shared and listen to gain understanding. Listen to gain that understanding, not simply just to respond. And so with that, I will turn it over to Dr. Swann.
Thank you so much, Dr. Graves. I'm going to share my screen. I'm so grateful to come here today and present to you. And I'm thankful also that Ms. Blue could join me here today. Now, some of you might have been wondering, why is an industrial engineer coming to talk to CALS about diversity? And I have to say, I was wondering that too, so you won't be alone there. Can some of the panelists, one or more of the panelists, confirm that you can see my slides, please? Nod or, yeah, great, thank you so much. And thank you so much for that kind introduction. Let me tell you a little bit more about who I am and why I'm the person standing here talking about diversity, types of issues, and COVID. As Dr. Graves mentioned, this should be a safe space. You should feel like you can say what you need to say, ask what you need to ask. And if you can't do it through Q&A, then also feel free to send an email to someone on the panelists, the leadership, or myself. And I would also ask that this is a safe place for me. So I am a white woman who grew up in Georgia. So what I'm going to be talking about today is not very much directly from my experience. I am trained as an engineer. I've been working in public health for more than 10 years now. But there's still things that I don't know, I'm sure. And I am sure that I will make some mistakes during the presentation. It might be in the language that I use and you have a different preference on your language, or it might be an incomplete understanding or a different perspective. You are welcome to challenge me or call me out on those things, especially if it's in a private email or chat or some kind of form of communication. But I just ask that you be forgiving of me and I'll be forgiving of you too. I've pulled information today from many different sources. And because primarily today is about education and discussion, I may not have the source listed on every single page. I do pull both from academic literature, from my own work in the space, and also from the news media. Now, I will say that the news media, everyone's aware that it has different levels of bias. I'm not expecting you to read this chart, but there is a chart that looks at the different perspectives of the news organizations. And I'm primarily pulling from this top dashed green box where the news media, and most of these are print types of publications like Washington Post or others, because they have an extensive news team that's really gone into some detail on some of the things that I'll be talking about. So as Dr. Graves mentioned, I'm in industrial and systems engineering here at NC State. I was formerly at Georgia Tech. I started working on pandemics back in 2007. And if you may recall, there was a pandemic that hit the United States in 2009. That was the H1N1 pandemic. I was brought on loan to the CDC as one of the science advisors there. And so I looked a lot at what was being done on the supply chain and the logistics. I had already been doing a lot of modeling in pandemics. I continued that work for a number of years. I've also done a lot of work looking at health systems such as Medicaid, which are the state insurance programs that often serve low-income populations, disabled populations, as well as children. So I've done a lot of looking at health access and those kinds of things. And I also talk to a lot of my colleagues and friends who are people of color. And here today, there's a special focus on people who are Black, Hispanic, or Native American. And so I'll be talking about some of the things that we've learned both through the news media and the academic publications, as well as through discussions. But again, you may have other experiences to share or other questions to ask. Now I will ask if one of the panelists can confirm how long you want me to talk, and you can just send it in a chat message to me and I'll be able to pull it up so that I time my presentation well. Here are some different references that I will touch on today and draw from, and these are ones that you certainly could go back and look at, and there are many others, as I mentioned. So the pandemic hit back, depending on how you count, China in December. It really started getting more attention in the US, I would say really more in March. And this is one of the early stories that I had read. And I was really struck by this one. And so I wanted to share it a little bit with you. Yes. And I am from Georgia. And so if you were watching the pandemic very early on, I was seeing that Albany, Georgia was the hot spot of infections in that state. And Albany is not Atlanta. It's not as dense. It would not be the place that you expect that the pandemic would hit the hardest. And here are a few pieces of that article that I mentioned there. This was an old-fashioned Southern funeral. During the weeks that followed, illnesses tore through that hometown. And Ms. Johnson was one of the features in the article, including 6 of her siblings. Can you imagine can you imagine having 6 siblings, first of all? I don't know how many people on the phone today might have 6 siblings. I don't. But can you imagine having 6 family members fall ill with COVID, and at a point in time when we really didn't know very much about it? If you continue reading this article, 90% of the deaths in these early weeks of the pandemic in Albany, Georgia, were people who are from the Black community. And if you read their comments about, people were being sent home, there were not enough nurses, there was not enough doctors, not enough intensive care beds, not enough personal protective equipment. People were being sent home. There's one story about a woman whose mother was sent home. She was a single mother caring for children, and now she had a sick woman coming home from the hospital who was not completely recovered. And she, they're begging the hospital not to send them yet because they weren't prepared. There are stories of how the diagnoses were late in some cases. So I think one woman was told that she had a urinary tract infection, and so for 3 days she was in the hospital diagnosed with a UTI, even though it was truly COVID. Now, I'm not blaming what happened there because this all was in the first part of March, and we hadn't even really realized that the pandemic had spread to a smaller town in Georgia. That's certainly not the first place that we expected. Here's another story that I read early on that I also found very telling. So this is outside Detroit. This one, the particular one, was in the Washington Post, and it covers other stories as well. So in this one, you can see that Collins is a commander from the sheriff's office. He was also a ballroom dancer. And they go to this party, and less than 3 weeks later, at least 7 partygoers were sick, and then dozens more ill at the sheriff's office. Mr. Collins passed away. Now that happened March 6th. I believe that was before NC State shut down. I'm pretty sure it was before the shelter in place was here in North Carolina. So I am not placing any kind of blame on the people who went to this event, but rather I'm highlighting a couple of things that happened and a couple of aspects that you see across several stories here. This story continues and talks about some cases in Nebraska. And this one, I think it was a meat packing factory, so that might be relevant to some of you in CALS. And there was a birthday party with a Hispanic population. There are also stories about how some of them who attended the party were afraid to talk about it. They were scared they were going to lose their job. They didn't really feel like they had a voice. So these are two of the stories that came out very early on. And I have a colleague, who was realizing that some of these things were happening, not only from these stories, but from other things. And I'll tell you, I thought in the beginning, well, this is just a little blip. It's coming to white people next. It might have hit these communities first, but I think I even said it, it's coming to the white population too, because COVID-19 doesn't recognize skin color. But there are other factors that lead several different groups and communities to be greater at risk. And I'm going to talk about some of those reasons. And today we know that there is a huge gap in the experience for what has happened for most whites in America compared to most Blacks, Hispanics, Native Americans. And then I'm not going to talk as much about Asians. I'll mention them just once because here they have a different kind of experience than some of those other communities do. Now, in that particular discussion, you will find I use different language. Sometimes I use Blacks, sometimes I use Hispanics. Some of it will be related to whatever word was used in the particular reference that I'm drawing upon. And in a podcast I recently listened to, it said you should ask people what they prefer to use. But there are too many people here today for me to ask each one of you. So I apologize if it's not the right word for you. So what are some factors in those stories? So some of the people that were in those stories were known to be in the category of essential workers. The story from Detroit, Michigan had people from the sheriff's office. The story from Nebraska had people in a meatpacking plant. These workers were still going to work after many of us were sheltering in place at home. There were also some social gatherings, and certainly we know even now that social gatherings have a relationship with COVID spread. And, there certainly could be some things like some communities gather more socially than others do, or have larger family members, or those kinds of things. There's another really important one, and I know this is true for Albany, Georgia. The people in this story had inadequate health care before that event ever occurred. And while the event itself, there is no blame associated there, but there is an underlying whole system that led to a place where many of them had comorbidities and had inadequate health care that they had access to in their areas, in there or others. And that could be true in Nebraska as well, especially for people who might not speak the language if they don't have Spanish translators. There's certainly communication challenges. So there could be a language barrier if someone speaks Spanish. There is messaging about the disease, and there have been some stories about different kinds of misinformation that's floated through different communities at different points in time. And there also are some examples in these stories and others where the decision makers were not listening. So let's talk a little bit more and go into a little bit more. Now, so are there disparities? What does this data look like? I told you that now we know there are disparities, but let's look at it. And so again, I'm going to be pulling from multiple data sources here. Here are some of them listed. I will say that there is less data available for the Native American communities than for other communities. It is poorly reported. It is reported in non-standard ways where different states are capturing it under different categories. So I'm not going to talk as much about that population, but I can tell you that there are concerns in those communities as well. So let's talk about the disparities. Let's look at some data. I'm an engineer, I like data. So here's some data. This is on percentage of cases. This was pulled from the CDC. This is percentage of cases by race ethnicity. Okay, so there you can see white non-Hispanics have about 44% of the positive identified cases. These are lab reported cases. Hispanics have about 29%. Blacks have about 18%, and then it's spread over others. These are deaths on the right-hand side. percentage of deaths. So Hispanic Latino is a little bit lower than the cases, so it's 16.5%. Blacks is a little bit higher, 20.8%. White non-Hispanics, 52.7%. But when you look at this, how do you know if there's a disparity or not? And I can tell you that this data really is not enough to know. You have to go further. And sometimes it's presented in the data sources that you look at, and sometimes it's not. And so I'll talk a little bit about that. So here's an example. One thing you need to know is how many people there are in the population. If I asked you how many Blacks are in the US population, or Hispanics, or whites, or other groups, I don't know that I could name those values right now. Now, maybe some of you can. And if you look at this, you can see that, for example, Black, and when this says Black alone, this is taken straight from the census. This means Black, not Hispanic. So that's a 13.4% in America. Look at the cases for Blacks, 17.9%, and the deaths among Blacks, 20.8%. So already you can see that there appear to be some differences for the Black population. Look at whites, 60%. Of the cases, they make up almost 44%, and of the deaths, they make up almost 52%. So somebody else has the share of cases that might otherwise have gone to whites if you just think about them as a percentage of the population. And in fact, if you take the numbers and you go a little bit deeper, just these numbers I have right here, you see you can get to a number that's the relative mortality risk. And you have to do a little calculation. It's not too complicated. I did it yesterday. And just from this data alone, and this is not the final answer here, but from this data alone, the mortality rate among Blacks is almost 2 times higher than whites. And I don't think it's that apparent when you just look at those percentages, because those percentages are not so far away from the population itself. But if you have a population that's only 13% of the population, but they have 21% of the deaths, then there's a problem, okay? And we're gonna look more into that. So now this one right here is independent of age. One of the things that we know about COVID is that mortality relates partially to age. Here's a picture of the deaths in America by age group, and you can see there are very few deaths of those who are under age 54. There are some, but there are many more in the population that's above 75. Now think about those subpopulations we saw on the previous slide. What does the age distribution look like for those? Actually, the Hispanic population, there are more children. It's a younger population. So this is a graph of age distribution right now of these different groups in America. Actually, this is from 2018. Whites are this top line here. The most common age among whites is 58 years old. Most common age among Hispanics is 11 years old. Most common age among Blacks is 27 years old. Now, if you just look at this picture and think about COVID, this should suggest that whites should have a larger percentage of the deaths if they're getting infected at a similar rate and had similar mortality. Another way to think about it is that we need to take those numbers on the previous page and we need to adjust them for the age so that we're really truly comparing apples to apples and oranges to oranges. Other people have done that. I'm not going to do it today. But what we can see is the following. On the top left, this is a chart from APM research. On the left-hand side is just the deaths, just as a percentage of the different populations that are listed here in the legend. It's Black, Latino, Indigenous, Pacific Islander, Asian, white. On the right-hand side is after you adjust that mortality rate for the ages. And look at the gap here between the white, which is this dark blue, and the Blacks, which is this green here. And not just between Blacks and whites, you can see that there are other groups here as well. And the CDC has a chart that I've put down here at the bottom. Look at the rate of cases in these different populations. The rate of positive identified cases is almost 3 times higher in the American Indian population compared to white non-Hispanics. For Blacks, it's 2.6 times higher. For Hispanics, 2.8 times higher. Now, data can always be biased in particular ways. Could this be that there is more testing being done in those 3 populations? It's possible, But I don't think it's that likely. I don't think that that many testing resources have been deployed to reservations or other areas where many American Indians live. There certainly have been some, but I don't think that they're being disproportionately tested. There may have been periods of time in which some of these groups might have been tested at a different rate, but I would actually hypothesize they've probably been tested at a lower rate than whites have. Look at the hospitalization rate, 5 times higher for American Indians than for whites, almost 5 times higher for Blacks, and 4.6 times higher for Hispanics. Look at the mortality rate. Here it's 1.4 times for American Indians, Black it's a little above 2, and Hispanics it's closer to 1. Okay, so this is saying there really truly is a gap in cases, hospitalizations, and deaths among these communities of color in comparison to white non-Hispanics. All right, so continuing, let's look at North Carolina for a minute and let's look at some of the other states. So here's the data I pulled from the North Carolina dashboard. Again, if you look just at this, how do you know if there's any kind of disparity at all? Cases, there are 23% identified in the Black or African American, 58% among whites. By ethnicity, there are 33% identified among Hispanics and 67% non-Hispanics. When I go to look at that dashboard for death data by race ethnicity, I can't find it. I don't think it's there. So only the cases are being reported with race ethnicity. And this does point to a problem that goes well beyond North Carolina. Not all of this data is publicly available. It's not all being collected. In fact, some studies have looked at what is the reporting rate, how many of our lab reported cases have race in them, and it's just under, so 20%, 21% are missing race information. For deaths, it's smaller, 5%. For cases, over 30% are missing ethnicity data. So, and of deaths, about 11% are missing ethnicity data. Now, we don't know who those would be attributed to. It might be that those are whites with missing race. It might be that they are people who are multiracial or in some other category. I just don't know. And if you look at states that have even worse reporting rates than what are true in North Carolina, you have to be careful about interpreting the data. So if you just look at this, so this is using the percentage of the population. I'm not doing an age adjustment in this. I'm just looking at the percentage of population. And on the left-hand side is race, and on the right-hand side is ethnicity. And if you look at the percentage of deaths, that's the green bar, in comparison to the cases, the red bar, and the population, the blue bar. You can see here that the rate of deaths and cases, but especially deaths in Blacks in North Carolina is higher. And if you look at whites, the death rate is lower. This one's not age adjusted. This gap would be even bigger if it were. Look on the right-hand side on the ethnicity, Hispanic or Latino, it looks like the cases tend to be high for the Hispanic or Latino population and that the death rate is lower. This is partly because of that age that I mentioned before, and these values are not age adjusted. Let's look at some other states. But those two in particular, deaths among Blacks and cases among Hispanics, have been identified as a potential area of concern for North Carolina. And I believe that was in the Emory site. If it wasn't the Emory one, that it was the Atlantic Racial Tracking site. So this is a study that was through September 15th, and I'm going to make this bigger, so don't worry if you can't read it yet. This is the age-adjusted mortality rates for Blacks and whites in America through September 15th, so it's missing some cases. And look at it here, and these are sorted by the biggest absolute value difference. So here, New York is at the top. The death mortality rate in white, so this is the people who may or may not have had the disease, just the percentage of the population, 72 deaths per 100,000 people. In Blacks, 324 deaths per 100,000 people. That is a huge difference. Imagine if you were in New York. Your experience as a Black person in New York may be very, very different than as a white person in New York. The next highest, Michigan. The next highest, New Jersey, Connecticut, Louisiana, Massachusetts. Why is this happening? I'm going to talk about some of the reasons, but I'm also going to tell you something else. Now, you don't see North Carolina yet on this one. Why is that? Well, North Carolina is below the average. The US average is down here at the bottom. North Carolina is below that. I work with numbers a lot. If you look at averages, there'll be a lot of people below the average and a lot of people above the average, right? It's not exactly 50%, but there will always be people worse than the average. Now, but Massachusetts has a lot of healthcare. So do I really think that the mortality risk in Massachusetts is going to be better than in Alabama, Mississippi, South Carolina, and some of these other states where we know there are a lot of problems? And in fact, I didn't even think about this until yesterday when I had shown this graph to a friend and colleague of mine who is a person of color, and she saw something different in this. And we talked about this is sorted by absolute value, so it's going to be sorted by the states that have had the most number of cases in some ways. These are also the states that were hit first and hardest, not explicitly first, but really have been through about 1/3 of the pandemic that the others of us have experienced. And if you think about this, for these other ones that are down here, I'll pick on Alabama because I have family members from Alabama, so maybe they'll forgive me. I don't know if they will or not. But suppose that on a given day or week that there's a little bit difference in mortality risk in that location, but that little bit is cumulative and it grows over time. So if there's a little bit of risk when you've had some of the population infected, and that is cumulatively, that gap is getting bigger as there are more and more cases. That could be what's happening here. And it could be that the rest of the states are just further behind and have not caught up yet. So I'm not necessarily saying that it is specifically something that these states have done. Now, I'm sure that there are things that could have been better throughout multiple states, multiple geographies, and other kinds of ways. But this graph has to be taken in the context of we're not done yet. Next chart is the same kind of chart for Latinos versus white Americans. I'm not going to blow this one up, but I'll tell you New York, District of Columbia, New Jersey, Maryland, Illinois, all of those are states that were hit much earlier than ones in the South were. Nebraska, now I don't know if Nebraska has a large Hispanic population or Latino population. Maybe they do in some of the industries there. Some of this could also be driven by small numbers. So it's hard to say exactly, but all of these ones at the top here are worse than the US average. North Carolina's at the bottom here, so we're not worse than the North Carolina average, but we do have a big gap in age-adjusted mortality rates for whites and Hispanics. Now, if you remember back to the North Carolina dashboard, the Hispanic deaths were actually lower, but that was ignoring age, and now this is saying we're not doing so great. I pulled up the numbers from Puerto Rico. The chart itself is September 15th. The Puerto Rico data is October 7th. But just as a comparison, Puerto Rico presumably has a pretty large Latino population. They've had 21 deaths per 100,000 people. Now, this is not age adjusted, but it is not, I think this suggests to me that it is not necessarily that people are having mortality because they are Hispanic, but rather because a whole host of other things that might be involved. This chart is for Asians. It is a little bit hard to see, so I blew up some of the ones at the top. There are some places where Asians have had worse mortality than whites. There are some places where Asians have had better mortality than whites. That's down here at the bottom, and these are age adjusted. So that's one of the reasons that I point to for Asians having a different experience, but there are others too. In America, they tend not to be as marginalized as some of these communities like Blacks and Hispanics and Native Americans. They do have their own challenges, and there are times when they've had discrimination against them, absolutely. And especially if this virus is attached to China in concept. Okay, so let's do a poll. I'm going to put a poll out there, and the way I'm going to do these polls, launch polling. So the question of the poll is the one on my slideshow, and then because that way I didn't have to change each question. So the question is, think of the people in your cell phone contacts. How many of you have somebody in your cell phone who has had COVID? So that's the question. Somebody that you could call up if you needed to. We'll see how many of our listeners are paying attention this morning. You didn't know I was going to make you work. And it's not stopping. There'll be about 5 more of these. So be ready. Okay, so far, well, I have to end polling to display the results. So I'm going to go ahead and end polling. So you can see these. In this group, we have share results, share them with you. 64% of the group knows somebody in their cell phone who has had COVID. 36% of the group does not know somebody in their cell phone who has had COVID. I'll tell you, in my cell phone, I don't know of somebody who has had COVID, not confirmed, lab confirmed. I have a family member, but it's a extended family and they are not in my cell phone. Okay, so let's go to the next poll. So let's go to question number 2. Okay, so question number 2. Okay, so now you're going to think of the people in your cell phone contacts. How many of you know someone who has died from COVID? And the reason I say think of someone in your cell phone contacts is I'm sure that we could all identify a friend of a friend or some kind of connection where we know of someone who has died from COVID. But this question is really getting at how close they may be to you. And it is okay to say not sure as well, certainly. Okay. All right, so I'm going to end the polling and go ahead and show the results. Okay, I'm sharing the results. 1 person knows somebody who has had COVID. 19 do not, and 1 is unsure. So the vast majority of the people on the phone right now don't know somebody who has died from COVID. Now let's think about the community of Black Americans and that mortality risk that we saw. New York is one example that the risk was 3 or 4 times higher that someone would have died from COVID. A recent survey of Black Americans said that 1 out of 3 Black Americans knew someone with COVID. I don't remember if it was who died from COVID or knew someone from COVID. And that poll was done back in June. So in general, for these communities that have been hit very strongly, they really feel what's going on. One of our staff members is from an area of New York, and she has had multiple family members with COVID. I think she knows 10 plus people who have had COVID. I have to tell you, my experience is very different than that. But that's important to think about and realize that this has been hitting several communities much harder. Now, I am not dismissing the impact that COVID has had on all communities across America. It has, from rural to suburban to urban, from Black to white to multiracial to unknown. COVID has hit everyone. It absolutely has. But today I'm more emphasizing and talking about how it has especially hard hit some of these other communities. Okay, so going back to the slides. So that one is from and it was a June 26 poll, and it looks like it is died from COVID, not just no COVID. Okay, so, and think about that when you think about faculty, staff, and students of color at this university or friends that you may know. One of my friends and colleagues sent me a story or an essay that was written in the news a couple months back. And the title of it was "White People Know Your Black Colleagues Are Not Okay." And COVID is just one of the things going on in this community. Of course, there are these issues around police brutality and injustice and all kinds of other issues. Today, we're focusing more on that COVID part. So why is there greater impact? And I can tell you, I'm going to make up a bunch of stuff in the next few slides. Now, I've done my research, I've read articles, I've read news stories, I've been reading them every day for months. But there are some things on here that are conjectures that are not entirely mathematically known at this point in time. In this here, these colored rectangles are the general process that might happen for a single individual as they experience COVID. So they're first susceptible. That means they're healthy. They don't have any immunity from the disease, and possibly they get exposed. Someone in their circle that they come in contact with exposes them to the disease. And if you're exposed and you acquire the disease, then at some point you become infectious to others. And a portion of those who have the disease are hospitalized, and a portion of those also eventually die. Only a portion, but let's look at each one of these pieces. But before I do that, I have another poll number 3. Okay, hold on, got to change my question here. Poll number 3, launch polling. First question, during the North Carolina shelter in place, did your job require you to work in person? And we're at a university, so, you know, I'm expecting that the answers will mostly go in a particular direction. But did your job require you to work in person, or could you work from home? I can tell you I came into the office, but it did not require that I come into the office. I could have worked from home. Okay, I'm going to go ahead and show what we have so far. Share results. Of the people on the phone right now, the vast majority, 88%, say that their job did not require them to work in person. Okay, good. So I'm going to stop that share. I'm going to go to my next question. Question number 4, launch polling. Question number 4, during the North Carolina shelter in place, outside of your own household, do you think you interacted with more than 4 people on an average day? Part of it could have been through your job. It could have been through if you had to take a transportation to get somewhere. It could have been your social activities. There's no blame here. All of this is, I think it's all anonymous, and I'm certainly not going to look at it. There are way too many questions, and I don't even know who most of you are, so it wouldn't matter if I saw a particular result. Thank you for participating. Okay, so I'll end that polling and go ahead and share it. Share results. Of the people today, 83% say that they did not interact with more than 4 people on an average day. Okay, thank you. All right, so I'm going back to the slides. So now let's look at this link between susceptible and exposed. So what are some of the factors that might impact somebody's likelihood of being exposed to the virus? And not just during the shelter in place, but during any time periods of the pandemic. There are several different things, like where you go, what you're doing, who you're seeing, how many people you see, how often you're going, what kind of personal protection equipment you have, what you know, and whether you're wearing your personal protection equipment, or what you know about COVID and how it's transmitted. And some of these things change over time. You know, what happened in March is different than what happened in July. But let's think about some of these for some of these marginalized communities. In particular, essential workers. What kinds of occupations someone is in? Agriculture, food, health, construction. Those are some of the occupations where it might be harder for you to work remotely. What kind of housing situation? How many people in your house? Hispanics are often living in houses that have more people, and I'm not just making that up. I've looked at the census data. I've used that in a model. Sometimes people are living in a multi-generational house. What kind of transportation? If someone has their own car, that's very different than if they're taking the bus or the train and having interaction with people that way. Any one of these might predispose someone to have a greater chance of being infected, especially during the early parts of the pandemic, when essential workers might have been primarily the ones that were exposed. So let's look at essential workers just a little bit. So healthcare, hospitals and nursing homes. So in North Carolina, approximately 5% of the population is working in healthcare at any given time. Hospitals, they were still going to work. Nursing homes. Nursing homes are a really interesting one. Hospitals, the majority of the staff would probably be full-time staff, and there would be some part-time workers. Some nursing homes use a lot of part-time workers, use contract workers who are working less than 20 hours a day, less than 20 hours a week at that particular location. But then they may go to a different nursing home and also work less than 20 hours a week at that nursing home. Part-time workers without insurance, probably without paid sick leave. If they're feeling some symptoms, are they going to stay home? Probably not. Somebody needs to mute. I'm sorry. Check your button and see if you need to mute. But if somebody it doesn't have paid sick leave, then it might be very difficult for them to afford to stay home. Police officers are among the essential workers. Police officers were in that story that I mentioned from the Detroit area. Food and agriculture were mentioned in the story from the Nebraska part of the story that I talked about. And meat packing plants were one of those early areas where there were some outbreaks. And I remember I read a number of articles about the case in South Dakota, and there were some really heartbreaking stories of what was done, not only there, but at some of the others. And there's some of the stories from the workers and from the workers' family members after the workers passed away. And they didn't feel like they could take a day off. And even though they were told you can take a day off, the company put in place incentives for working up to some cumulative number of hours. You would get special bonuses. This is after the pandemic had started and after multiple outbreaks had occurred. They put these incentives in that kept people coming to work, people who needed that income. Now, I know that the people on this phone and those that are watching this know far more about food and agriculture than I do, but those are some areas where there have been some of the outbreaks of COVID. I'm going to need to switch earpieces just 1 second. I'll do that. You hear me now? Somebody nod. Thank you very much. Agriculture is another one. So there was a case in New Jersey where, and that is certainly a field where, an occupation where we have seen spread of the disease. There was a case in New Jersey where the workers were being transported on these vans from where they lived to the fields. And these vans were not well ventilated. They weren't wearing masks in these situations. And they were also living in crowded conditions, the workers were. And so that was another case where things spread. I didn't list construction industry, but that one is another one. And that one has been one of the factors at play in North Carolina, for example. And there are others, I'm sure, that those are just a few examples of them. Cases over time. So if it is true that essential workers is a factor, then we should see more cases early on and then maybe flattening out. The truth is we don't know. I cannot find the data on cases over time in Blacks, Latinos, Native Americans, white. This is the only part that I've been able to find is for April and May. And this one came from the New York Times, and they had sued the federal government to get the data. I'm not saying that the government is trying to hide the data. They have a lot on their plate, and I may want a different kind of data than what they're reporting, but it's very hard to truly understand what's going on in some of these areas. Okay, let's go back to this list. So once someone has been infected, what might lead them to have greater risk for hospitalization than someone else? So the age is one factor, weight is a factor, your existing health, whether you have diabetes, cardiovascular conditions, COPD, former smokers, some of those different things might put you at greater risk. Your existing level of immunity, and one of the factors that affects your immunity is stress. So these are some of the factors that might relate to your hospitalization risk. And what does that mean for these populations that we were talking about? Well, some of the folks who are listening today and later know a lot about the options that are available in different communities for food choices. Is there fresh produce? Is it quality produce? That's something that other people could talk about. We do know that the rate of diabetes is higher among Blacks and Hispanics, and I believe among Native Americans than among whites. And diabetes is a particular risk factor for COVID. Certainly stress. And, you know, we've had all of these other things going on that some people have called the racial pandemic, with George Floyd, the police brutality associated with that, the protests, the other deaths that have occurred. And that has led to a lot of stress. And even the language and the discourse that is occurring is leading to a lot of stress. And that can affect someone's likelihood of being hospitalized. Some other factors, whether they have a hospital that's close to them, you know, is another one. So let's go to the next one. So what might make the difference between dying or not? And here are a couple of examples. Again, there could be more. One is if you have delayed care because you didn't get to the hospital in time, and there could be several reasons for that. Insufficient treatment. You weren't, you know, I mentioned the woman who was in the hospital and they diagnosed her with a UTI, not with COVID. So poor care. Providers not listening. The system overloaded. New York, New Jersey were completely overloaded at that point in time. We know more now about flattening that peak. We've had more time now to make sure that we have the healthcare resources in place. So hopefully that part of it is improving. Let me comment about providers not listening. There are studies that show that a Black person who has a provider who is Black has better healthcare outcomes. Now, you know, why is that? There can be lots of different reasons. It could be language and communication. It could be discrimination, lots of different things, lots of different reasons why, and there are not that many Black providers, not relative to the number of people in the population, but there is lots of both anecdote and evidence that Black or Hispanic or Native American people may not be heard as well by the providers or the hospitals or others, that what they're saying is not fully acted on. So health access to specialists, health insurance is another part, education, both general education like degrees as well as any kind of education about the virus itself, discrimination, history in the health system. I'll talk about this one in a minute. Immigration concerns for those who might have different status and they may be concerned about going to the hospital. So there is a framework for access to care that comes from the social science literature, and I wanted to touch on it. Okay, good. So I just wanted to make sure I'm not taking too much time. Thank you for that message. So we're good, because I was starting to talk faster. I don't know if you could tell. So access to care has multiple components to it. One is geographical access. So this might be how far you have to drive. If you are here at NC State campus, you don't have to drive that far to get to a hospital or to get to a specialist of any kind. And in the Raleigh, Durham, Chapel Hill area, we have lots of infectious disease specialists also, but not just infectious disease specialists. We have lots of other healthcare. Financial affordability. This includes both whether you have health insurance, and it includes any copays that you might have to pay for going to the hospital. And if you think about going to the hospital, you know, that could be a significant financial burden. And so you might, if you have low income or low wealth, you may not initially go. Sufficient availability of resources. These are the 5 A's. That's why the A's are in quotes. Availability means that there's enough of them. There is this story, I think it was out of Pittsburgh, but it might have been Philadelphia, about a woman doctor, a Black woman doctor, who saw that there was not enough testing in the populations that she was serving. And so she stood up a mobile testing van herself. She funded it partly out of her own money, and then there ended up being some donors who contributed to it. And they greatly increased the testing that was available to these marginalized communities. Made a huge difference. It shouldn't have had to be done by that doctor and her own funding. And this is something, you know, certainly some things happened perhaps back in March and April, and maybe we didn't have as much testing capacity. I certainly hope that this is something that's been addressed. And I know that public health departments do look at these things. Public health departments are also stretched very thin. But this, I imagine it does continue to remain an issue. One of the other A's, accommodation of preferences, and the other one, acceptability of options. So these include things like, can you get care after 5 o'clock or on a weekend? If you want a female doctor, can you get a female doctor? If you, some various things like that. If you need to speak in Spanish, can you find somebody who can translate for you? So access to care is a complicated thing where all of these could relate to your ability to access care. So this framework does miss some other things. It does not account for continuity over time. It does not account for potential discrimination by providers or others. So that would be on top of any other gaps that we might have in these 5 that I've listed here. I've done some studies around access to care, and access to care tends to be lower in 2 kinds of communities. It tends to be lower in rural communities. You can imagine that geographical access would be hard, access to specialists would be hard. It is also low in urban areas of low income, urban areas of poverty. So it is low in both of those areas. So that probably suggests that both whites and blacks and Hispanics could all have some issues around access to care, depending on where they live and what their full situation is. And when I say access to care, it's multiple parts of the COVID system. It could be the testing, as I mentioned. It could be healthcare services, like getting the hospital, or even services in advance of COVID, like getting adequate diabetes care. And eventually, this could also mean vaccine, depending on how vaccine is distributed. It was Philadelphia. Thank you so much. I couldn't remember which of the P's. I've been to both of them, but I couldn't remember. Another poll. Let's do another poll here. I learned how to do this generic polling from a colleague of ours at NC State. So question number 5, if you were asked to tell a family member about the Tuskegee experiments, do you think you could do that? Have you heard enough about it? And I can tell you, I know a little bit about it, and I'm only going to tell you enough to make me dangerous, which means that I don't know enough because I've forgotten it. But this is a question that's helpful towards understanding some of the context around some of the different perspectives on healthcare. Okay, we'll wait for a couple more people to vote. Those of you who ran over to get your coffee and come right back. Thank you, a couple more, and then I'll stop the polling. All right, I'm gonna end the polling now. Let's see our results, share results. Okay, so approximately half of the group thinks they could tell a family member about the Tuskegee experiments. And, I see that there's several people who I would conjecture identify with communities of color that we're talking about today who are on the panel today. And so maybe they are more likely. I certainly know that there are many things that I don't know about and that are from US history. So Tuskegee experiments were done by the US health system, and they were looking at syphilis, the sexually transmitted disease. And they studied a group of Black men for 70 years. They watched them go through syphilis without providing them treatment for the disease. We had a treatment that could cure syphilis, and for 70 years, we did not give it to those men. This was a really important story and history that's part of the experience of Black Americans. And it is just perhaps one of the reasons that sometimes people of color are distrustful of the health system. So I watched a TV show, I think it was Face the Nation on one of the major news channels from Sunday, and I watched a YouTube where they spoke with 6 voters and they asked them a variety of questions, and they had picked people from very different backgrounds and experiences. And then they asked the question, if a vaccine for COVID comes in November, how likely are you to take the vaccine? And I wish I had put that on the poll today. I don't think I have that one. But of the 6 people on the TV screen, 2 of them said maybe. And others verbally articulated, I am not going to be a guinea pig. Now, I am not saying that person should take the vaccine if it comes in November, but what I can say is there is significant skepticism and hesitancy and concern over healthcare, but especially things like a COVID vaccine. And I am expecting that could potentially lead to greater gaps in immunization coverage once we do have a safe and effective vaccine. And there are things that public health is doing about this, but what this means is that we could have gaps that continue to grow. So this is, we have a model, a simulation, computer simulation of COVID in the state of North Carolina. And for those of you who are familiar with models, it is an SEIR type of model that is an agent-based over a network where we're using census tract information. So this has people of different ages from using the census data, of different race, ethnicities, of different household sizes. And each one of those is independent, just determined at the census tract level. And that's because we don't have better data that allows us to know exactly how big the household size is for the community of whites at the census tract level as compared to others. And then we have diabetes rates that are different by race, ethnicity, according to the state average, which I don't have off the top of my head, but it is higher among Blacks and Native Americans. On the left-hand side, I'm showing you a slide that projects the cumulative infections over the course of the COVID pandemic in North Carolina with only those differences, just the differences of age, race, household size, and those are only at the census tract. Those are not individual differences. And diabetes rates. And cases are not related to diabetes rates. So even just looking at household size and where people are living, like urban and rural areas, we expect that the cumulative cases would be higher for Hispanics, highest for Hispanics, and lowest for whites. Okay, so this is really driven by household size, including the number of children and where people are living. Urban areas tend to get hit sooner or harder than rural areas. Now let's look at deaths. Deaths, the cumulative deaths show a little bit more for Blacks than for the others. And this is consistent with the data that we're seeing out of North Carolina. And in this model right now, we only have the barest tip of the iceberg in terms of some of the differences that are really truly occurring among these populations. So what I would say is that if you just took age and household size, it's only accounting for a little bit of the gap that we see in North Carolina. And diabetes is only accounting for a little bit of the gap. There are other gaps that go beyond that. And there are other things that we'll be adding to the model over time, but I just wanted to give you a flavor of that since I'm an engineer and I use computers a lot. And this work was done by a PhD student, Eric Rosenstrom, in collaboration with my colleagues, Julie Ivey, Maria Mayorga, former Georgia Tech colleague, Pinar Kiskinajek. The true gap is much bigger because it is more systematic, and I don't have all of it in the model right now. Okay, so let's assume, or let's take as a fact that some people have been impacted by COVID. Let's go a little bit further. And by the way, participants, I do suggest that you share your questions as soon as you think of them because you'll forget them. I'm covering a lot of things, a lot of slides, a lot of graphs, so you'll forget them. So please put your questions in there. Cascading effects of disease. So suppose you have to go to the hospital. This reduces your money because you have to pay for that. It could reduce your safety net or what you have in the bank. There's the stress related to knowing people who died, and the mental health, the anxiety, the depression, which many people across America are feeling, but certainly those who have known somebody that had family members directly impacted by COVID. Longer term health implications. There is a phrase that's being used called long haulers, and these can be people of any skin color that seem to not, that the disease, they don't fully recover physically. It may go on for months or longer, we don't know yet. This can include both cognitive effects as well as physical effects. Reduce labor productivity, so you're absent from work and you might not be at your full potential even afterwards. mental health, both from the isolation and from the stress. So there are many cascading effects of the disease itself. And then you have the cascading effects of the pandemic as a whole because of the system impacts. So what do those cascading impacts of the pandemic look like? Well, unemployment is one. Those of you on the phone haven't lost your job. There are people across the country who have. It's more often people in services like restaurants and bars, and small businesses. But there are others, even large companies are starting to lay off people. This is a study from the Urban Institute, and this was really April, May, June. So this is the share of adults in households where at least one person expects to lose employment income in the next 4 weeks. National average, the yellow is black, the black population is the yellow bar, and then the Latino population is the third bar, the black column. They should have switched that. That would have been much easier, wouldn't it? And you can see here that these communities have higher expected loss of employment. The one on the bottom, this is from Texas. This is just non-elderly adults not covered by insurance, health insurance, and this is in April, May, June. The state average says blacks are a little bit lower than the state average. Hispanics or Latinos are much higher, particularly in the later weeks here in the May to June time period. This is a chart from Chicago looking at food insufficiency, the share of adults in households where there was often or sometimes not enough food in the previous week. Metro average is in blue, the next column is the black population, and the third column is the Latino population. So not only do they have, do blacks and Hispanics and others have a higher rate of mortality, you know, they are also experiencing some of these other things, loss of income, insufficient food for them and their family members. And there are many, many systematic reasons that this has occurred. And one of them is because of the kind of job that you work. Those of us who work at the university tend to be a little bit more protected. That is probably changing for the areas of auxiliary services at the university, where there are people who will have to be furloughed because we simply are not taking in the revenues that we were before. Really millions and millions of dollars lost, not only at this university, but at organizations all across the country. And this is going to have a series of cascading effects. Cascading effects in terms of housing. So the CARES Act helped with federally guaranteed mortgages, which is about 70% of existing mortgages. They helped landlords that have federally guaranteed mortgages, and they helped with the HUD, so that's low income housing. Most of the rental market was not covered at all. So 72% of the rental market was not covered. Now look at some of these charts and figures about rental. We know if you've looked at the history of racism, it has been harder for blacks to get mortgages in America. I am not blaming anyone on the phone today for that. I doubt that you were the one sitting in the bank who made a decision on whether to give someone a mortgage or not. But the simple fact is that it has been harder for them to get mortgages. So there are more of them living in rentals than for other populations. Here are some hot spots around the country on the left. The top right figure is the home ownership rates by race and ethnicity. You can see Hispanics and blacks are on the lower side, with only 42 to 48% having home ownership. And then on the bottom is a survey. This is a US Census Bureau Pulse survey, the confidence to pay the next month's rent by race. And no confidence in being able to pay the rent. Blacks, the pinkish column, is higher than whites, the dark yellow. Slight confidence, blacks have higher than whites. But if you go to the high confidence to pay next month's rent by race, 47% of whites and only 24% of blacks. So this CARES Act was an important step, but it did not solve the problem for all people in America. This is now having its own, excuse me, having its own implications, as there are risks of evictions now. And so, and I don't have the chart on evictions. Oh, you can see it in this US map here. There are different laws being passed, and a lot of these eviction policies are being done at state and local levels, not at a federal level. So Georgia here, which is where I grew up, ranked 3rd, has left decisions on evictions to local discretion. North Carolina, evictions can take place in person or via Zoom in North Carolina, so it makes it easier for landlords to evict. Florida has suspended evictions until September 1st. So there's a difference in a state policy given there. Now, landlords are feeling the pain too. I'm not saying that they're not. Some of them may have been helped because they had federally guaranteed mortgages, and some of them have not. People all across the spectrum are struggling, but I do think that we're going to see a greater number of evictions, a greater number of people who may end up on the streets, and this has widespread implications both for short and longer term. Moving on, I want to talk just a little bit about things going on globally. It's only a little bit, but these are the recent rates, and I've sorted this by deaths per 100,000 because that allows me to get some kind of estimate of how far along they are in the pandemic. So maybe 10 to 25% of the people in Peru have already been exposed to COVID-19. For this next group of countries, it's in the bucket of 5 to 20%, and it's a range because there are different infection fatality rates or different undercounting rates of deaths, and also a range because we, yeah, that's the main reason for the range. And then, you know, we're nowhere close to herd immunity. But look at the countries that are on this list. Of course, the US is on this list, and these are ranked by the highest compared to the rest of the world. We've got Peru, Bolivia, Chile, Brazil, Spain, Ecuador, Mexico, Panama, Colombia, all on this list here. And that's deaths, even if that population might have a number of children. So this has been sweeping across Central and South America. And actually, if you look, you might notice you don't really see African countries here much. Let's look at the, oh, I don't have the next set of countries. There are 2 or 3 reasons for that. One is what the comorbidities could be in some countries versus others. Africa doesn't have as high a rate of diabetes or cardiovascular, and that is partly because there's so many infectious and communicable diseases that they die from other things rather than having diabetes, which requires you to be alive longer. But some of the African countries also have a lot of experience in widespread disease outbreaks, with the Ebola outbreak that was in Liberia, Sierra Leone, and DRC. And in particular, Nigeria had a really excellent Ebola response, and they just shut it down. There were thousands of nurses or hundreds of nurses making thousands of phone calls for contact tracing when Ebola came into their airport, and they really know how to activate their public health system. There may be other reasons. They maybe were not doing as much global travel, so the disease may have been slower to get there. Some of their areas are not as dense, but and so if you look at this, you know, so it's not just that COVID might impact someone who has dark skin. That's not necessarily true. There are all of these other factors. Also, if you were to dive down into some of these countries, Sweden and others, you would find that there is a higher rate of mortality among the non-white populations in these countries. The UK is also in that. I did not bring that reference today, but it is true. And there were also been stories about Singapore where when they were doing their pandemic response in the beginning, they kind of forgot about the migrants living in these group congregate housing, and the disease got into that migrant community and it just spread like wildfire. So Singapore went from this great response on cases and deaths to realizing that things had really gotten out of control because they forgot about these marginalized communities. So let me talk about vaccines for a couple of minutes, and continue to put your questions and answers in here, because as I'm telling you, you'll forget. Vaccine candidates, we have several. These are just ones that are in phase 3. I especially want you to look at this one at the top. Pfizer, Moderna is another one that's pretty important for the US, and then Johnson & Johnson and AstraZeneca are the other ones and Novavax. But the vaccine, one of the things that we know is that the Pfizer has stated, Moderna has stated, Pfizer requires what's called a ultra low cold chain. This means it's beyond what you normally have at the medical, our medical supply chain. It's beyond what your doctor would have. Some of the hospitals would have it, but not every single facility. So cities are likely to have more of these sub 80 freezers, and/or you would need to be able to supply dry ice. And again, this will be easier in a major city than it would be in a rural area or a smaller city. This is likely to make the last mile distribution much more difficult, including for rural areas and also potentially for areas with lower infrastructure. Approximately 25 countries in the world have the infrastructure for the ultra low cold chain. There are 3 or 4 of them in Africa that do, because of the recent Ebola vaccine, but otherwise it's mostly the countries in Europe and the UK, and the US and some others. But even within the United States, I think we're going to see significant challenges for these vaccines that are currently furthest along in the process. US has also pulled out of the COVAX system, where we would say that we're going to provide some of our vaccine to other countries. This also means if our vaccines do not work, then we would not have access to those technologies from other countries. The Gavi organization is working with others to help companies be ready, but what I'm expecting is that there are going to be different vaccine choices. And if an ultra low cold chain is the best choice for efficacy and effectiveness, it may not be chosen by a country that doesn't have that kind of infrastructure. So this could lead to some worldwide disparities. In the US and other locations, priority populations are not completely finalized. There has been a lot of talk of prioritizing marginalized communities through various kinds of ways, and so that's really important. But not everything is prioritized, and truth be told, some of the devil's in the details, right? It will depend on how the execution is done by states. There is also significant vaccine hesitancy, as I mentioned before, and I think this is especially true of the Black community because of the history of things that have happened in the healthcare system. Oh, so this all sounds terrible. We have terrible mortality cases, everything. Can we do anything? And we're getting closer to the end now, just so you'll know. But I wanted to give you some ideas. Again, some of these are made up. Some of them I pulled from news articles. But at least can we think about doing something? So as a systems person, I think of it in a systems kind of way. Recognize the problem, identify it, define it, measure it, analyze the system, improve, intervene, evaluate, repeat that process, right? Very structured framework. So here we really need to make sure that this, that the gaps have been identified, that the problem has been defined. And here we also need to make sure that we, the global we, not just we on the phone, but we are listening to the communities that have been impacted by this. Data, data, data. It is not sufficient what we have right now. And I am continuing to push, and others, who have more power, to push for better and more data to really understand the extent of the problem, understand the reasons for the problem, and understand the solutions for the problem. Scientists and researchers do have roles to play throughout this space, and I'm going to talk about some more specifics on the next slide as well. And here are many different organizations and types of interventions that might be involved here, and I'm going to talk about some more specific ones. Evaluate, repeat, more data, more listening. That's really important here. And again, I'm a white woman from the South, so I can tell you that what I'm talking about today has largely not been my experience during COVID. It's what I have learned about through other mechanisms. What can be done? Here's some short and midterm types of interventions. So one is, I mentioned that article, but be aware that your students or colleagues of color may not be okay. This is a more stressful time. It is stressful for everybody. It's stressful in my household. It's stressful for my faculty, staff, and students. I do think that it is more stressful for people from these marginalized communities. So be aware of that when you're teaching. Check on your colleagues sometime. Don't all go and check on the same person today because that would be overwhelming, but check on your colleagues sometimes. Improve the data collection and provision. We need to be doing this every day. Improve diagnostic testing in underserved communities and continue to ask for these kinds of things. Provide Spanish language translators. Examine workplace provision around PPE. And this is especially true in the food and agriculture industries, which I know this particular college has some relationships to. It's also true for nursing homes and others. Develop housing alternatives for isolation. I know that North Carolina's Department of DHHS, Health and Human Services, does have housing alternatives if someone cannot isolate at home because there are too many people in the household. So they do have some. Work with key community members. So again, this is not my experience, but there are others whose experience it truly is. And so they can also help define some of the interventions. Even here at NC State, it could be that some of our students of color could also be at greater risk for severe outcomes and other kinds of things. So we need to be thinking about them as well. Targeted messaging is really important. Messaging that identifies and recognizes the problems that exist for that community. And it may be different. It may be different for Blacks and Hispanics. It may be different for Blacks in Raleigh than it is for Blacks in Hickory or somewhere else. It may be different for Hispanics who work in construction than Hispanics who work in the food industry. You know, it may be different really across the board, but as we can better define the problem, then that may lead to more targeted messaging. Sorry, I've got two screens going on, trying to make sure I'm getting to that. Okay, longer term, there are much bigger issues than just these ones about better testing and better response during COVID. We have long-term problems that are affecting our communities of color in the US especially. Health insurance, access to quality health care. There are issues around income, education, wealth gaps that are in part a result of the policies and processes that have been put in place. Again, I'm not casting blame on you today. You were unlikely to have been the one who put in place these policies. But if you can recognize them and help move for change, that over the longer term that might help. And in public health, equity is part of the decision making, and so be aware of that and thoughtful about that. Equity here does not necessarily mean the same for every person. In social sciences, it's sometimes there's horizontal equity and vertical equity, and sometimes equity is defined as the supply to meet the necessary need. And if you think, even forget about race and ethnicity for a moment, if you think about the need across the population being age driven, that people of older ages are at greater risk than people of younger ages, then we might imagine how the vaccine could be allocated earlier to some groups. Healthcare workers are in the priority population, earlier to some groups than others. So really be thoughtful about how equity plays into a variety of different decisions. This is a chart from the NIH-CM Foundation about health in the Latinx community, and here's some strategies for change over on this far right-hand side. I'm also happy to provide these slides to anybody who wants them. Anti-racism training in health systems, community health centers and workers. That's a really important one, is to have community workers. Workforce representation, address housing and food security, school health programs, access to childcare and paid sick leave. That's a really important one, a number of things. I know I have talked a lot this morning. We don't have a lot of time for questions, but I would love to see if there are some questions. I do want to thank the people who reviewed my presentation and gave me feedback on it, colleagues in my department, and have you know, helped educate me throughout this journey, as we should all continue to educate ourselves.
So, Dr. Swann, I have a question from someone that gave you, they said you had an excellent analysis and presentation, and they said that one of the candidates referenced this last night. They said, how could information access and accuracy affect the COVID results that you described?
Okay, so I'm looking at the question. I see it's from Eric Davis. Last March, the COVID recommendations to the public was use your best judgment. I think what that means is back when we didn't know as much, we weren't told don't go to a party or whatever it was. Now, that was the same recommendation from one of the vice presidential debate participants last night. How could information access and accuracy affect the COVID results that you described? I'm not sure if those two comments are related or not related. Information access, there are a couple of different kinds of information here. If it's information about COVID and how it spreads, public health messaging needs to make sure that it's able to reach all of the communities where this is important. And there has been, in some cases, misinformation spreading on the internet, including that it was said, it was going around Illinois at the time, that Black people couldn't get COVID. Maybe this was because they weren't seeing, somebody wasn't seeing as many cases in Africa, but clearly that is not true. Public health messaging needs to make sure that they're reaching all of these different communities. Native Americans and the ones in Arizona may have different concerns than the ones in North Carolina, reaching Hispanics in different areas, reaching Blacks, reaching whites, reaching everyone. So that's part of it, and accuracy. I do believe that we have had inconsistent messaging about COVID-19. I can tell you that as a scientist, I believe that the mortality rate from COVID is 5 to 10 times higher than the flu, 5 to 10 times higher. So one person who gets the flu, one person who gets COVID, 5 to 10 times higher to die. Not only that, but for flu, we have some existing immunity. We have existing immunity from previous flu seasons and from vaccines. And for COVID, we have none. The combination of those two things is really, really strong. And if you look at where the US is so far, the numbers were in my slides. I think it was 5 to 20%. We've had about 15% of our population exposed to COVID, and we have already had 200,000 deaths. If we expose another 2 or 3 times the number of people, those deaths are going to grow a lot. So I do think that there is a role for better information access and accuracy. Ms. Blue.
So in the Q&A, we did get a statement. One individual says, I think Fauci is transparent. If he says it's safe, I will probably take the vaccine.
I think that that is mostly true. I do like Dr. Fauci a lot. I respect him. I think that there are things beyond his control sometimes. There will be a lot of people reviewing the data, not just the FDA and the White House Coronavirus Task Force. And just recently, I think it was yesterday, the FDA had been pushing for some modifications to the guidelines for the vaccine approval, that they would wait until 2 months after the vaccines had been given and follow the individuals to look for additional side effects. And I think it was approved just yesterday by the White House, which means that we're unlikely to see vaccine in October and really even November, but it does give us a little more time to see what's going on with those initial 30,000 or more participants on each one of those vaccine trials.
So we also have, given the U.S. history and the current contentious nature and relationship of marginalized communities with the U.S. leadership, what would be the best kind of information to disseminate to marginalized communities to help them feel less reluctant to get care and even vaccines when they become available?
This is not my primary research area. I do know that there is some evidence that, in some studies that suggest that there are some sources that Black Americans may trust more than others. So they tend to trust their primary care provider. They may trust, if they go to a place of worship, a church, they may trust the pastor at the church. They may trust their neighbors. And, you know, really, again, this is not my area of expertise, but there is, you know, there are innovative ways that we could work with communities. We, being the public health system globally, can work with communities, including Blacks and Hispanics and others, to make sure that the information is getting out, but also that the concerns are being heard, the concerns about the vaccine efficacy, and not wanting to be a guinea pig, as the one woman said. And I would also turn it to you and ask you, who do you think, who would you trust if there are some of you who are hesitant about vaccines? Who would you trust? So maybe if, you know, maybe Dr. Fauci is one of that. Maybe the U.S. Surgeon General is one. He is an African American, and there are others, maybe.
Jerome is worrisome. That's all I'm gonna say.
Thank you, Ms. Blue. See, not everybody, right? I mean, it doesn't matter. It's not only about the color of their skin, right?
All skin folk and kin folk.
That's right. That's right. What else, Ms. Blue?
I think I heard you speak about inequities, but I'm not sure you addressed Alice's question fully. It says, how can we best use the data to take action towards changing the inequities?
Oh, so, and I don't know if this question is specific to COVID. How can we use information about COVID to take action towards changing the inequities? But I can tell you this. Right now, we don't fully know whether the increased rate of cases is because of essential workers or if it's because of information and messaging. That's just one example. And we don't know how much is due to this and how much is due to that. We need to know more about that, because if we know that it's due to essential workers, or if we know it's due to information messaging, then there are different interventions to solve that problem, right? Messaging is a different intervention. Communication is a different intervention. If we know it's about having adequate personal protective equipment, or not just having adequate equipment, but having high quality equipment. Right now, I've seen studies that talk about, that have looked at the kinds of masks that are used and how it should be multiple layers. And you know, these net gaiters that sometimes are used are actually worse in some cases than having no mask at all, if it, depending on what kind of material it's about. So that could be another factor. You know, what kinds of masks are people using in different communities? So that's what I mean about, if we really look at it as a system and think about all of these different things, well, could it be this, could it be that, and really try to understand each one of those things, then we'll understand which interventions would make sense. Now, there's not time to do all of that in the way that we would like to. In some sense, we have to throw the, I've forgotten what the phrase is, but we've got to throw the whole toolbox at it, right? We've got to be doing multiple things. Maybe we need to be talking about masks. Maybe we need to be talking about social gatherings. Maybe we need to remind people that singing in church is a risk factor because of what is known about how someone articulates aerosols when they sing compared to when they talk. There will be maybe multiple kinds of things that are necessary. And then we've got the ones that are based on the longer term issues around greater rates of diabetes, lower rates of health insurance. And those are solved in a different way through policies and mobile clinics and other kinds of things.
We have someone that says, even once a vaccine is produced, proven to be effective and FDA approved, what would be the theoretical timeline before it is widely available?
That is a great question, and it depends on whether you want the government answer or whether you want my answer. And of course it changes daily. It changed yesterday when this new guidance came out. I do not expect vaccine to be widely available this fall. I expect this fall, if there are doses available, it is going to be for a small number of people in very targeted roles, like healthcare workers taking care of COVID patients in hospitals. That's not even healthcare workers in nursing homes. Maybe it'll get to healthcare workers in nursing homes. But in terms of me, I do not expect I will have access to the vaccine this fall. Maybe I could have access by March. Maybe some other people who are in front of me in line might have access in February. For other people who might be after me, I don't know exactly where I am in the current list because it's not clear how they count university faculty, but maybe those won't have access until June or August next year. So I am not really truly expecting much before we bring back our students in January or after.
Do you have recommendations for how people might advocate for themselves, if there's a diagnosis and they just don't feel comfortable with it, do you have any recommendations for how folks might go about using their voice for their own personal advocacy or a family member's advocacy if they're just not comfortable with the diagnosis?
That is a great question. And I don't know if you've ever had an experience in healthcare. I had my child broke a leg. We were in the hospital. You know, I've had a couple of kids, so I've given birth in a hospital, and often one feels unheard. I, as a white woman, also feel unheard sometimes. I do think, and you know, even when it's my family member, I do think that it's really important to have an ally. If you have a family member or a friend or whomever who can help that voice be heard, you may be the caregiver of the child or parent, and so but then also your spouse or significant other or your sibling or another family member. Two voices is more important than one sometimes. I do also find that for people who have some education about healthcare, and that doesn't mean a degree, I mean educate yourself on the internet, and I would include NC State employees as people who could go and find some information out, that the more knowledgeable your questions can be, then the greater likelihood that someone will listen or pay attention to you. You can ask for formal second reviews, you know, a second opinion, so to speak, like if you've gotten a cancer diagnosis and don't agree with the treatment. That does take more time. That might be less likely for COVID. COVID, there's still a lot unknown. There are, I'm sure, still cases where someone shows up and, you know, like there are some cases where somebody repeatedly tested negative for COVID, but they had all the symptoms, and they finally called up a doctor friend of theirs, and that doctor friend of theirs says, yes, I think you have COVID. There are people who don't seem to perform on that test. So if you search the internet and you can identify these stories, if you can share it, if you feel comfortable sharing it with others and they can identify the stories, those can help. There may be other solutions that people who are from public health or social sciences know as well.
Dr. Swann, can we do a hard stop at this point and let those who have to be somewhere go off the line, and so they don't feel uncomfortable doing that? And if you want to, if you can, answer the other questions, but I've answered the other questions that came in. We'd appreciate that as well.
Yes, thank you so much for your time today, and I know we are at the end. Thank you.
So we don't have any Q&As remaining, and I think I've captured everything that the panel was able to put in the chat since they couldn't put it in Q&A. So I don't see any other questions.
Okay, thank you so much, Dr. Swann. It was very enlightening for me, I know for sure. And I am very appreciative that you took the time to come and share this information with us.
Yes, absolutely. And you know, I like numbers as well. I like data, and I think this equips us with the knowledge. It equips us with power in a sense, because we can use this information towards enacting some practices. You know, Dr. Swann, you mentioned a number of different methods that we could take, or strategies that we could take depending upon what the data is telling us. And I just think that this is a great example of why it's important for us to get accurate data, and that everything is transparent.
So I guess we'll remind everybody that if you have some feedback for this session, to please submit it to the Go NCSU CALS conversation feedback form. And if you have any other questions that weren't answered during the session, please submit it to the CALS and Justice questions form. And we'll do our best to get to those, and we'll even see if we can't get input from Dr. Swann on some of those. So where you can find different resources for these things, and Dr. Swann, if you don't mind sending me the PowerPoint. I'll include it so that people can have that to use. And it'll be on our website, the Go NCSU EDU CALS Diversity. And you can also visit the Office for Institutional and Equity and Diversity website for more resources. So on your screen, you can see the next conversations in this series. We're going to talk about pandemic myth busting, coronavirus predictions, and coronavirus best practices. We hope to see everyone at those next discussions.
Absolutely. Thank you to everyone. Thank you. We appreciate your support and engagement.
Thank you, Dr. Swann.